Welcome to this essential guide on understanding and managing small for gestational age. As a woman or a healthcare professional, it's crucial to be informed about small for gestational age. Today we will explore the definition, etiology and pathophysiology, risk factors, clinical features, differential diagnosis, investigations, and management of small for gestational age. Small for gestational age, SGA, refers to an estimated fetal weight, EFW, or abdominal circumference, AC, below the 10th centile on a customized growth chart. Severe SGA refers to an EFW or AC below the 3rd centile. Around 60% of SGA fetuses are constitutionally small, meaning that fetal growth is appropriate for maternal size and ethnicity. Some fetuses with SGA, particularly severe SGA, will have fetal growth restriction, FGR, as well. FGR implies a pathological restriction of the genetic growth potential. This can be placental or non-placental mediated growth restriction. As a result, growth-restricted fetuses may manifest evidence of fetal compromise, e.g. abnormal Doppler studies, reduced amniotic fluid volume. SGA fetuses are divided into the following categories. Constitutionally small, fetal growth restriction, FGR, either non-placental mediated growth restriction or placental mediated growth restriction. SGA fetuses are constitutionally small, meaning that they have reached their genetic growth potential, in keeping with maternal size and ethnicity. Non-placental mediated growth restriction. Fetuses who have not reached their growth potential, for reasons other than those related to the placenta. Examples include fetuses with chromosomal or structural abnormalities, fetal infection, or inborn errors of metabolism. Placental mediated growth restriction. Fetuses who have not reached their growth potential due to problems with the placenta, such as abnormal implantation and vasculature. Examples include preeclampsia, autoimmune disease, thrombophilia, renal disease, and essential hypertension. Maternal factors can also affect the transfer of nutrients across the placenta, such as low pre-pregnancy weight, malnutrition, or severe anemia. All women should be assessed for SGA risk factors at their booking visit. The presence of risk factors warrants increased pregnancy surveillance. Broadly, SGA risk factors can be divided into major, odds ratio 2.0, and minor, odds ratio 2.0. Major risk factors for SGA include previous stillbirth, previous SGA fetus, cocaine use, maternal age 40 years, maternal disease, chronic hypertension, renal impairment, diabetes with vascular disease, antiphospholipid syndrome, threatened miscarriage, low pregnancy-associated plasma protein A, PAP-A, a placental hormone, preeclampsia, cigarette smoking. Minor risk factors for SGA include nulliparity, in vitro fertilization singleton, maternal BMI 20 or 25, previous preeclampsia. Any woman with one major risk factor will be referred for serial growth scans, which are essential to monitor and diagnose SGA. If a woman has 3 or more minor risk factors, she should be referred for uterine artery Doppler at 20 to 24 weeks gestation. Women with abnormal uterine artery Doppler should also be referred for serial growth scans. A thorough obstetric history at the booking visit is vital to identify any of the risk factors listed above. A constitutionally small SGA fetus is unlikely to present with any maternal symptoms. Preeclampsia is a major risk factor for SGA. Women with preeclampsia may be asymptomatic, diagnosed on routine BP urinalysis, but can present with severe headache, visual disturbances, epigastric pain, and sudden onset edema of the hands, face, and feet. For patients with no risk factors, SGA fetuses are usually detected during routine obstetric assessment. Typical findings of a suspected SGA fetus include symphysis fundal height below the 10th centile, low estimated fetal weight, serial measurements suggesting slow or static growth. Relevant bedside investigations performed on every pregnant woman include blood pressure to screen for preeclampsia, urine dipstick to screen for preeclampsia, cardiotocography, CTG. If fetal compromise is suspected, CTG can be used to assess fetal heart rate, from which the degree of fetal hypoxia can be inferred. Additional laboratory investigations which may be appropriate for severe SGA include serological screening for congenital cytomegalovirus and toxoplasmosis infection, karyotyping for fetuses with structural abnormalities, amniocentesis antenatally. Serial ultrasound scans, USS, are the key investigative tool for diagnosis and surveillance of SGA fetuses performed from 26 to 28 weeks gestation. For fetuses at risk of SGA, USS measurement of size and assessment of well-being with umbilical artery Doppler is performed every 3 to 4 weeks until delivery. Umbilical artery Doppler is used to assess fetal well-being. Table 1 shows examples of normal and abnormal umbilical Doppler waveforms. If there is a normal Doppler, it should be repeated in at least 14 days. An abnormal Doppler should be repeated more frequently, and expediting delivery should be considered. Middle cerebral artery Doppler and ductus venosus. Doppler can also be used to help time delivery of the SGA fetus. If these are abnormal, then some degree of harm may have already occurred to the fetus, and delivery should be planned immediately, often by cesarean section, as the fetus will not tolerate any potential hypoxia in labor. The diagnosis of SGA is made from USS assessment of EFW or AC. SGA equals EFW or AC is less than the 10th centile on a customized growth chart. Severe SGA, EFW or AC less than the 3rd centile on a customized growth chart. Managing modifiable risk factors during pregnancy is essential, including smoking cessation, drug counseling. Women with comorbidities, e.g. hypertension, renal disease, should be medically optimized before and during pregnancy to reduce the risk of SGA. In women at high risk of preeclampsia, antiplatelet agents, e.g. aspirin 150 mg daily, should be commenced at 12 weeks gestation until the birth of the baby. Expedited delivery must be considered for an SGA fetus with evidence of fetal compromise. Delivery may be induced either vaginally or by C-section, depending on other features of the pregnancy. 37 weeks, umbilical artery Doppler, absent reversed EDF, recommend cesarean section. CHASH 37 weeks, umbilical artery Doppler, abnormal, offer induction of labor. At 37 weeks, umbilical artery Doppler, normal, offer induction of labor. Women with a SGA fetus between 24 plus 0 and 35 plus 6 weeks of gestation, where delivery is being contemplated, should also receive a single course of antenatal corticosteroids. Structurally normal SGA fetuses are at increased risk of perinatal mortality and morbidity. However, the majority of adverse outcomes are concentrated in the FGR group. Neonatal complications of FGR include iatrogenic prematurity, antenatal or intrapartum asphyxia, operative delivery, perinatal death including stillbirth, neonatal hypoglycemia and hypocalcemia, necrotizing enterocolitis. After the neonatal period, babies born with FGR are more likely to suffer long-term disability, e.g. cerebral palsy. They are also more likely to suffer from type 2 diabetes and coronary heart disease in their adult life. Thank you for joining us in this educational journey on understanding small for gestational age. Stay informed and take proactive steps to safeguard your health.